What is value in healthcare? Thanks. If you had a way of organizing and delivering care that yielded better health and better quality for the population, and lower levels of inequality for the advantaged and disadvantaged, and if you could get that for lower costs compared to other ways of organizing care, would you buy that? Better health, better quality, less inequality for lower cost. That's not a bad definition for value in healthcare. And as Andrew just told us, that's what Barbara Starfield's work shows are the characteristics of healthcare systems that are organized around primary care. And yet, we're skeptical. It sounds too good to be true, and it is too good to be true. If you have a fundamentalist belief in a simplified world where the whole is just the sum of the parts. One of the reasons that Barbara Starfield is so revered is that she understood that healthcare and health is more than just the sum of the parts. That to get a functional system, you just don't try to optimize and incentivize each little commodity of healthcare and wishfully expect the whole to work. You don't try to crudely command and control from the top. Barbara's research showed the world the high-level effects of primary care. And she gave us clues as to the complex mechanisms by which these effects are achieved on the ground. How many parts that are much more than commodities interact to create a whole that is greater than the sum. But there's a paradox of primary care. Reductionist research looks at one disease at a time and does clinical trials that wash out all the complex social and environmental determinants that might differ between two groups that are compared, and actually excludes people that have all these complex, messy comorbidities that people live with. And then based on that narrow reductionist scientific evidence, we develop our clinical guidelines. We develop what our measures of quality are. And when you use those measures of quality, lots of research has compared primary care to specialty care, and shows that by those narrowly defined measures, primary care quality is less than the quality of care provided by someone who's just focusing on that one disease. And yet if we raise our gaze a little bit and look at the medical outcome study, that again, just focusing on one disease, one chronic disease at a time, compared care by primary care versus specialty care, and look at the functional health status of whole people, we find similar levels of functional health status but lower cost for primary care. And if we look at Kathleen Baker's work, using some of those same reductionist quality measures, but measured at the level of the system, measured across the 50 states in the US, we find that more primary care is associated in quite a linear way with better quality of care at the system level. And surprising to some, greater levels of specialty care is associated at the system level with less quality of care. That doesn't mean we don't need specialists, but it means if we don't have the balance right, we need to emphasize, we need to value, we need to support primary care more. And then, of course, we know from Dr. Starfield's work that systems based on primary care have healthier populations, better and more equitable outcomes at lower cost. But what provides this value? I had a chance yesterday to spend the day with the Episcopal scholars, the rising stars in family medicine. And I asked them this question, and here's what they said. They told a lot of rich stories about the subtle integrative work that they do that defies reductionist measurement. One person said that she focuses on the most important thing for the person at this moment and does that over time, and over time that adds up to something else. Someone else said, we take the long view. We put things in context. We focus on quality of life, and so that when people are at the end of life, they have the possibility of death with dignity and optimizing their ability to do what's important to them at other times in life. Someone else said, when someone comes to me after having seen 5 specialists, I start taking medicines away to get to a number of 6 or 7 that the patient can actually probably take. And in doing that, I reduce the problems, the errors, the harms that we cause from all this polypharmacy that happens from just focusing on one disease at a time and adding those up. Olga Vollman emailed me last night, actually, after the conversation, and says, we leverage relationships. She says, I counsel parents during a child child visit. We listen for teachable moments and link with community resources. Justin Matter said, "Paradoxes persist when paradigms are wrong." Paradoxes persist when paradigms are wrong. The dominant measurement and payment paradigm is about disease, not about people and community. He said we need to change a paradigm that doesn't work. Andrew also showed us about the tenets of primary care that Dr. Starfield in the IOM and others have talked about. And it's not just a list, it's about the complex interaction of 5 different things. It's about being first contact, providing first contact access to a healthcare system. If I have chest pain, I don't have to decide, is that my heart, is that my lungs, is that my musculoskeletal system, is it reflux, is it psychological? I can just go and someone will look at me, having a comprehensive whole person approach, integrating care across acute illness, chronic disease, prevention, mental health, and family, and coordinating care across narrowly focused care across different settings, doing that all in the context of relationships with the individual and the family and the community. Ian McWhinney talked about focusing on population and community, but with an acquaintance with the particulars. This dual gaze, this iteration between the parts and the whole, between the person and the population, is what turns rationing care into personalizing care, turns crude disease protocols into healing relationships, turns fragmentation into integration. How do we measure, incentivize, and pay to get this value? There are 4 levels of care. And I'm going to draw something out here that's in more detail on page 21 of your handout here. But the basic level of care at the bottom here of the pyramid, we have fundamental care, we have basic care. And that's caring for the patient's acute complaint, it's caring for single chronic diseases, it's proactively trying to squeeze in disease management and prevention, it's doing mental health care, it's providing care for families. That's the basic level of care. The next level of care is integrated care. Most people on Medicare in the US have multiple chronic conditions. Most people coming in for primary care come in with multiple chronic conditions. Integrating care means trying to bring together what's the optimal for that, but not even just for the disease. How do we integrate that with what we can do that day for prevention, or what they're worried about that day, or the family member that they're worried about, or when we can find a disease that provides a teachable moment for a preventive health behavior. That's integrated care. When we follow those trails, we often look bad on the individual disease-specific measures. This low level, this basic care, right now is all we know how to measure for quality. It's frankly all our information systems to support us in doing. And I worry that as we focus on this, we unintentionally devalue these other levels of care. So the next level of care above integrated is prioritized care. Iona Heath talked about this in terms of integrating the biotechnical and the biographical, choosing what's most important in that moment for that individual, and actually choosing what's most important over the course of a group. I mean, in every day, we actually prioritize care. Do we spend more time with this problem or with this person? How do we do linkages with other people in our group, with the community resources? We prioritize. That's actually how we help manage resources. When you do that crudely from above, it's crude, it's rationing. You have clunky systems. When you use those high-level systems to support that front-level function, that's when you really get personalized care. And so that's what I would call the top level of care is healing. When you ask people what they mean about healing, they'd like cure, please, if possible. But if not, they'd like to draw meaning from what they're going through. They'd like us to help them to get over what they're dealing with so that they can get on with what's important in their lives. They'd like us to abide with them. They'd like us to stick with them over time. How do we measure so that we can incentivize behavior? How do we externalize the intrinsic motivation that so many primary care people have to do these higher level functions? How do we externalize that motivation to commodities of care that can be measured and bought and sold is the wrong question. How do we turn primary care into chronic disease managers is the wrong question. How do we enhance the productivity of primary care as measured by the number of people we can crank through an office in a day is the wrong question. I think it's ironic that we take the most complex function in healthcare and try to cram that into little 10-minute aliquots. And if you focus on one thing, you get 30 or 40 minutes and get paid more. How did we end up with that? I mean, that's just ironic. That's just backwards. That really needs to be rethought. Justin had it right. We need to change the paradigm that doesn't work. I got some better questions, though, more helpful questions. How do we understand the added value of primary care beyond disease care? How do we invest in primary care teams and support the development of relationships as well as the delivery of commodities of care? How do we support the integrating, personalizing, prioritizing functions that are essential to meeting the triple aim? I hope you'll keep this paradox, but more importantly, the higher level functions of primary care in mind in the next couple of days as we start thinking about measurement and payment and developing of teams. Thank you.